Welcome. I'm Dr. Tara McCannel. I'm an associate clinical professor in the Department of Ophthalmology at the University of California, Los Angeles. And I want to thank you for joining us today for our webinar. And today I'd like to talk to you about eye cancer, and particularly eye cancer surgery at UCLA. And this is the first part of a three-part series, and I hope that you will enjoy this presentation and join us for all of the remainder. And at any time, if you have questions, feel free to direct them to us. I will do my best to answer after the session. So in this presentation about ocular melanoma surgery, I'm going to review with you some basic information about ocular melanoma. We're going to talk about surgery using brachytherapy treatment with or without vitrectomy. I'm going to talk to you a little bit about what it's like to go through the week where a person is wearing the brachytherapy plaque, what to expect. I'm going to discuss a little bit about how we take this out in the office. And I'm also going to talk to you a little bit about what to expect in the immediate postoperative period about visual recovery and how the vision does. Let's review a little bit about ocular melanoma. The word ocular melanoma refers to a very rare type of cancer in the eye. The word ocular melanoma, uveal melanoma, choroidal melanoma, those all refer to the same type of cancer, this form of cancer that forms from pigmented cells within the eye. It is the most common primary intraocular tumor of adults. Yet it is rare. There are only about 5 to 6 cases per million per year in North America. So that's about 2,100 cases in the United States. We don't know why people get ocular melanoma. There are no specific risk factors that have been identified, although there is quite a lot of literature exploring different associations. We do know, however, that people who have blue or green eyes may be more susceptible to developing ocular melanoma, and that we see this condition in people who have less pigmentation of their skin rather than more pigmentation of their skin. However, it's important to point out that here at UCLA we have seen pretty much every race affected by ocular melanoma. So let me share with you where this cancer forms. So here is a cartoon of the eye, and you can see that the front of the eye, which is on this side of the picture, the cornea, which is the outer coat of the eye, the pupil, which is the opening in the iris, and the lens, which is right here. This is the part of the eye that forms a cataract when a person gets older. Everything behind the lens, over here, we call this the posterior segment. And the posterior segment is made up of the retina, the choroid, the vitreous humor. The vitreous humor fills this space, and it is clear and transparent. In a person who develops an ocular melanoma, which is depicted by this brown spot here, the tumor actually grows underneath the retina from the pigmented cells in the choroid. So this is a typical location that we might see in ocular melanoma in the eye. Here's an example of an eye that has been removed or enucleated that contains an ocular melanoma. So here we are. Here is the ocular melanoma underneath the retina. And you can see that the retina is detached here. This thin layer of retina normally lies flat against the back of the eye wall. And in many cases, a person can have a retinal detachment in association with the choroidal melanoma. How do we detect ocular melanoma in patients? Well, there's a few ways. Oftentimes, we detect a tumor in the eye from a routine eye examination. And currently, when a person goes to their optometrist or other eye care provider, they may be offered to have photographs taken of the retina. And increasingly, we have found that these photographs pick up pigmented spots or areas of concern that we might not otherwise know of. And this is usually before a person has any symptoms. Which leads me to the next reason how ocular melanoma is diagnosed. It is picked up by a person who starts to have their vision affected. So the symptoms that a person with an ocular melanoma may have can be blurry vision, it can be noticing a blind spot or a spot in their vision where they see darkness. They may also see flashes or flickering that wasn't there before. And keep in mind, though, that these are symptoms that can be associated with many ocular diseases, not just ocular melanoma, but rarely we do find melanomas in people who have these symptoms. And certainly a person may already know that they have a freckle or a benign nevus in their eye, and over time it is possible that in some nevi they can transform into melanoma, just like an unusual freckle on the skin can change to form into a melanoma. Here are some examples of what melanoma look like, and I share these with you because they look many different ways. Here's an example of a melanoma on this side of the screen that is very big and dark, and it is coming from the periphery or the corner of the eye, and is not affecting the center of the vision, which is right here. Here is another example of a melanoma that has a little less pigmentation associated with it. Here are some other examples of melanoma, and you can see that they look very different. They have different amounts of pigment. Some don't really look that pigmented. And here's an example of an iris melanoma, because the iris is part of the uvea and the choroid, which we believe is where these cancers originate. And you can see that in the iris melanoma, this lesion has really minimal pigment at all, and it looks like a pink spot on the eye. So again, melanomas can look many different ways. How does melanoma affect patients? Really in two main ways. Melanoma can affect a person's sight, and melanoma can affect a person's life. So vision loss can happen from a melanoma because the tumor itself can disrupt some of the sensitive structures in the eye that are responsible for vision, such as the macula, which is the part of the eye that we use for central sight and recognizing faces. Also, when a person has a melanoma treated, some of the side effects of treatment can lead to reduced vision. So these are the common ways that melanoma can affect sight. What about metastasis? Metastasis is when a cancer spreads beyond the organ where it started and goes elsewhere in the body. And melanoma of the eye has a risk of the cancer spreading elsewhere, and we call that metastasis. And that is probably the most important reason how these cancers can affect people. If ocular melanoma were to spread beyond the eye, it tends to go to the liver preferentially. And it's important to note that at the time the eye melanoma is diagnosed, it is unusual to already have cancer in the rest of the body. Let's talk a little bit about the surgery for ocular melanoma. And in this picture, this is a picture taken during the surgery where a melanoma is being treated. This gold device here is the plaque itself, and within it is embedded the seeds of radiation that are calculated to treat the specific tumor. And you can see that the tissues of the eye have been opened, and these black strings are tied onto muscles of the eye, which help turn the eye. So we can get at the melanoma by simply turning the eye. A lot of people think that the eye is removed for the surgery, but we actually do not remove the eye. So we call this surgery of putting in the plaque, this is what we call brachytherapy. And brachytherapy is a general term that implies that we are using seeds of radiation to treat a cancer. Brachytherapy we use in prostate cancer, in some brain cancers. We use it commonly to treat eye cancers. And using brachytherapy, which is the plaque with the seeds of radiation in it, is the most common way that ocular melanomas are treated in the United States. We recommend that treatment be performed by enucleation or removal of the eye in unusual situations, but particularly if the vision is very poor at the time of diagnosis, because usually further treatment of the tumor can cause more complications to the eye, and if a person doesn't see well to begin with, we recommend having the eye removed rather than surgery to try to save the eye. The radiation treatment plan, which is how we decide to design the plaque, is determined by the clinical examination, so what the cancer looks like when it's examined, by ultrasonography, which is a test where we can get specific measurements of the dimension of the cancer, and also by our radiation oncology team. And we work together to come up slightly different plans for each person depending on how big the cancer is, where it may be located, and this is very key in order to establish an appropriate treatment. And I'm very grateful to the team that we have at UCLA, because we work very well together and really come up with all sorts of plans for things that may be a little atypical. And as I mentioned, our plaques are individually customized depending on the patient, the location of their tumor, and that's how we devise our treatments here at UCLA. So a few things to note. When you have your plaque surgery, this is all outpatient surgery. The surgery happens in an outpatient setting, so there's no need to stay overnight in the hospital for this. Patients get discharged after a period of observation after their surgery and can go home. We use what we call monitored anesthetic care, which puts a person in a twilight state with intravenous, so medication through the vein, giving drugs that help a person feel relaxed or help to sedate a person so that they can choose to be more alert, or if they want to be completely out, we can still do this monitored anesthetic care without having to do a general anesthesia. And it's only in rare situations where we would recommend that a patient undergo general anesthesia for this treatment. And largely that's because a general anesthesia is a lot more stressful on the body than a local anesthesia. During the surgery, there is either no to minimal feeling of the procedure happening. And because a person may be slightly awake, if they feel uncomfortable, they can speak up and ask for some more medication, and we can help take care of the discomfort. After the surgery, when a person leaves the operating room, they will have a bandage on the eye. We will put a lead patch, which we put over the eye, and that's included in the bandage. A person will wear a wristband to indicate that there is a small source of radiation on the body. And all these things are to just be cautious and preventive. For example, if a person has a sudden medical event during the time that the plaque is on the body, it's important for us to know so that we can make a plan to remove the plaque at the appropriate time. I want to address a few key points. The eye is not removed from the eye socket during the treatment. I'm often asked, how do you get to the tumor if you're not taking the eye out? Well, the surface layer of the eye is covered in something called conjunctiva, and that's actually the superficial part of the whites of our eyes. And there's a lot of blood vessels in there, and that layer we can open up, and that reveals the four main muscles which move the eye, side to side and up and down, and I'll show a diagram of this. So as soon as we have those muscles, we can turn the eye. So we actually put a string around each muscle so the eye can be turned. And this allows plenty of exposure so that we can get to even places in the eye that are at the very back. And during the surgery, we use our ultrasonography at the time of the operation so that we can confirm the size of the melanoma in case it has changed during the time that we've made the diagnosis and the treatment. We can also confirm how accurately that plaque is sitting behind the eye. Is it covering the tumor properly? Is it not centered properly? Is it missing an edge? All these things we can tell. And ultrasonography is very key to having an accurate treatment. So here is a diagram that just shows where these muscles are of the eye. This diagram shows all the muscles, but the main four, and so these are the muscles that move the eye from side to side. And these muscles, top and bottom, move the eye up and down. And these are the main muscles that move the eye in the basic positions. There are other muscles too that help with up and down gaze, but these are the ones that allow us to get exposure during the surgery. So this is an example of what's happening in the operation. You can see that this is an operating room, so everything is performed under sterile conditions. We wear operating gowns, we wear gloves. You really can't see any of the patient in this picture except of the eyeball, which is actually right over here. And you can see that we have tubing and things to monitor a person, but this is what it looks like during the operation. And because we have a radiation physicist, we have a radiation oncologist, we have an ultrasonographer, we have many visiting doctors, there can be a lot of people in the operating room. And this is an example of the ultrasonography that occurs. And when a person comes into the clinic for the first time to be evaluated, we will often do an ultrasound. And we take the ultrasound and the ultrasound machine and all the equipment and our ultrasonographer. We all are in the operating room together during the surgery. And you can see, let me see if this will play here. I'll back up. So this is the ultrasound probe wrapped in a drape so that it remains sterile when it contacts the patient's eye, which is under here. And we have the screen set up over here. So here's the melanoma, and what we do is when the plaque goes on, we can actually measure how much coverage there is beyond the tumor being treated. So we have a lot of documentation of what actually happens during the surgery. And everybody in the room has to agree that things are good to go before we move on to the next step. So let's talk a little bit about vitrectomy with plaque. If a person has a small melanoma, and by small, usually we consider that to be less than 2 millimeters, then we can use vitrectomy instruments, which are instruments that are used in retinal surgery, to take a little tiny piece of tissue from the tumor so that we can send it for genetic testing, which helps give us information about the cancer prognosis. And when a person has this procedure as part of their surgery, there are no additional precautions, there's no special positioning. We just recommend that people take it easy the night of the surgery until we see them the next day. Now, in people who have larger sized melanomas, after we put the plaque in, just as you've seen, and we've confirmed the location, what we then do is we can remove the vitreous humor of the eye, which fills the space of the ocular cavity, and we replace it with silicone oil, which is a substance that we use to fix retinal detachments with normally. And what this substance does is it actually shields healthy non-tumor tissue from getting the radiation, and it reduces the exposure of the radiation. And so what we have found at UCLA, we've been doing this for at least 6 or 7 years now, fairly routinely, and we find that when silicone oil is used in combination with plaque treatment, we get less patients with radiation retinopathy, and we have better vision because there's less radiation that escapes to the parts of the eye that don't need the treatment. And we saw in an earlier picture that in many cases a melanoma may be associated with the retinal attachment in the eye. When the eye is filled with a silicone oil bubble, what this does is it actually treats the retinal detachment as the tumor is dying. And all these things result in better vision. So if the retina is in the right spot, if we can minimize the radiation, at the end of the day, that eye is going to see better than without those interventions. When we use an oil bubble in the eye, we will often ask that a person try to sleep on their stomach or on either side for the first night of surgery. Rarely do we have people do positioning beyond the first night, but these are things to keep in mind because of the differences in the treatment. So let me just go in a little bit more detail about how the silicone oil works. When you treat a melanoma in the eye, and the melanoma is here indicated by tumor, we put the plaque on the outside of the eye, and here's the plaque covering the melanoma. When the radiation works, there's some extra rays of radiation that go beyond the tumor that needs to be treated, which may be harmful to healthy tissue that is not tumor tissue in the eye. When we do a vitrectomy, we take out the vitreous humor and we replace the fluid with the silicone oil bubble, which limits the radiation beyond the melanoma being treated. And here's an example of when the radiation from the plaque affects the tumor, it is actually shielded. The remainder of the eye is shielded by the silicone oil bubble. So this is, in basic terms, how the silicone oil bubble can be helpful to help shield the radiation in the eye undergoing treatment. So let's talk a bit about the week that the plaque is in the eye. This is an example of how our patches look. It's black underneath and there's some white tape on the surface. And these things we discard afterwards unless a person wants to keep it. So we recommend that once you've come home from the hospital and you're comfortable in your surroundings, that you wear the lead patch when you're around people, your family, your friends, and pets to minimize the radiation that may come off of the plaque. We recommend that you wear nothing when you're by yourself. So if you're settled in your bedroom or in part of the house where you plan to spend some time and you're by yourself, it's best not to have anything covering your eye. That means no bandages, no patch. We want you to keep your eye open during that time, and that's because if your eye is unpatched, you can monitor your vision better. If something starts to look a little unusual or different, you can let us know right away. And when you have the opportunity to use both your eyes together, this reduces the possibility that you may have some double vision at the end. When you keep your eye that's been treated patched and covered and you don't use it, and it's not seeing as clearly, your brain will have a tendency to ignore that eye, so that when you finally take the patch off, it may be a little harder to adjust to using both eyes together. So you might as well start getting used to it during the time the treatment is in place. I often get asked about discomfort and pain. Fortunately, most of the people who receive this treatment have very little pain associated with the surgery and the treatment of the melanoma. Most of our patients need a Tylenol or an Advil or ibuprofen for their discomfort. What I recommend is that people use these together because these two different pain medications, which can be purchased over the counter, work in different ways. So there is no risk of cross-reaction between these two pain medicines. What also is helpful is using some ice to help with the swelling. There may be some swelling of the tissues around the eye. You can get some ice in a little bag, or even some frozen peas, I've told people, and wrap it in a cloth and hold it over the eye. This often soothes the eye, and you may not need medication for pain. The other thing is I'm asked is, what can I do during this time? Well, if you feel comfortable and your eye is not bothering you, you can really do activities that are comfortable. If you're doing something that makes the eye feel sore, I would recommend holding off until the procedure is over and you've recovered a little bit more. Let me tell you some normal things to expect during the time that the plaque is in place. It's normal that you may have slightly swollen eyelids. And in some people who have a lot of swelling, they may not be able to even open the eye right after the surgery. This is fairly typical. And especially if a person is lying on their stomach or on their side, a lot of the fluid that accumulates in the tissues will sort of pool forward, so that what's actually in the eyelids is a lot of extra fluid. And it's normal to have sort of mild to moderate aching sensation of the eye. And the very first day after surgery, when we see you and take the patch off, is usually the most uncomfortable. And after that, with the patch off and the eye sort of open, a lot of people feel that things feel much better as the days go on through that week. It's normal for the eye to look very bloody. So if you look in the mirror, the white of the eye may look entirely red. It may look very disturbing, but this is normal because all those tissues on the surface have been opened and put back again, so it's normal for them to look very red. And it's also normal to have a lot of tearing out of that eye because our eyes naturally respond to changes in the environment, and having a surgery where the tissues are moved and are slightly uneven and not smooth will cause tearing, and from the swelling and inflammation, it's normal to have a lot of running. And what a lot of people notice is that the running also comes out of their nose, and that's because the fluid from the tears drains through the nose. So you may have a runny nose and a lot of tearing in the eye. Again, this is very normal and not anything to be alarmed about. And it's normal that for the time the plaque is in your eye, you may have some double vision. And when the plaque comes out, oftentimes this improves with normal use of the eye. And finally, of course, the vision. It's normal right after surgery to have blurry vision. And the blurry vision can be related to many things. First of all, the surface of the eye has been opened and closed, so it's irregular, so the tears are not going to lie smoothly across the surface. So all the tissues around the eye will be a little swollen, so that's going to cause some distortion and blurriness. Also, the eye itself is going to have some inflammation because it has undergone a procedure. That itself can cause some blurry vision. So let's talk about things that one should be concerned about. What is abnormal? And if you have any of these concerns, or even if you have something concerning on the normal list, we do want to hear from you. It's abnormal if the discomfort is getting worse. So it's the day after surgery and it feels a little sore, then the next day it actually feels more sore. If it's not the same or getting better, we want to hear about it. If a person starts to get worsening headache around the tissues of the eye, like in the forehead or in that side of the face that seems to be getting a bit worse, that could be increased swelling, but it also might mean that the pressure in the eye might be elevated, and we want to hear about that so we can check you to be safe. And finally, if it seems like the vision is getting worse, not the same or better after surgery, we want to hear about that too. Many of these things are maybe difficult to diagnose the cause of some of these over the telephone, so we may ask that you come in and we check you to be sure. So usually it's the first 2 days after surgery that may be the most uncomfortable, but most people feel that as that week goes on, things feel better. I always recommend that it's important not to put yourself in the bed and be at bed rest. You know, your eye is closed, the surgery is finished, and a lot of the healing is the swelling and just having those sedation medications pass through the body. So if you can move around and are feeling fairly comfortable, I recommend people walk around, go for a walk, just be as active as you can be, well, unless it's causing discomfort, but we want you to start moving so that this will help speed up your recovery. Well, because you do have a small source of radiation on the eye, and the amount of radiation that can be detected beyond the eye, even though it is very minimal, we still recommend that people not go into places where there's crowds of people. So don't go to the shopping mall, or go to a restaurant, or go to an office area, or go to a school. You just wait until that plaque comes out, then you can do that. Let's talk about removal of the plaques in the office. And this is something that we've been doing now for the past 2 years, and it's been very helpful because we don't have to have people go twice to the operating room. You only go to the operating room one time for the surgery, and the rest we can take care of in the office. So it's less time in the operating room and less anesthesia. You don't have to be sedated and have all those medications and drugs on board if we don't need them. So how this works is we put a local anesthetic in the tissues of the eye, and we do use a needle for that, but the eye is numb. So there may be a little feeling of discomfort, and then the sensations of the eye they disappear because of the anesthetic. There are strings that are attached to the plaque itself that we tuck underneath some of the tissues in the eye. So that's what we can find where the plaque is by just finding the strings up at the front. And once we pull out one of the strings that anchors the plaque in place, the plaque is now free and can be removed. So what we recommend for the removal morning, when you're coming in and the plaque is going to be taken out, we recommend that you don't have anything to eat or drink midnight the night before. And we call that being NPO. And the reason for that is just in case the eye happens to be still sore, a person can be walked over to our operating room and have the procedure done without any delay. If you've had breakfast, then it becomes a difficult issue for being able to be in the operating room. We want to make sure that you've had nothing to eat or drink, just in case. Sometimes when we move a muscle to put the plaque in the proper position, we put that back, and because there's a little more manipulation, sometimes we plan to bring a person back to the operating room so that that can be a little bit more comfortable than doing that in the office. Let's talk a bit about visual recovery after surgery, and most of this applies to the immediate time. So the final vision of how a person does often depends on how that vision is when they first come in and see us. So if a person has very poor vision from the get-go, we usually don't expect the vision to improve significantly from that point. So the better the vision is at the first visit, the greater the chance that vision may be maintained or minimally affected in the immediate time after surgery. The larger the tumor is, the greater the retinal detachment, which can also influence visual recovery. And vision is almost always blurry, as I mentioned before, due to some local inflammation of the tissues after surgery. So when silicone oil is placed in the eye to shield the radiation, as we talked about, there may be more immediate blurring in the postoperative period. So when the patch comes off, it seems like the vision is really poor. But there are ways that we can check the vision and examine the eye to know that everything is going as planned. And for people who have the oil bubble put in the eye, I often say give it 4 to 8 weeks for the vision to improve to the way it was at the baseline when they actually came in before the surgery. The more extensive the retinal detachment, the longer the time it may take for the vision to actually get better. So there's many factors that can influence how we give our estimates as to what to expect. So it's important to know the different conditions in each person. So although this is something to do with vision as well, sometimes people who have a melanoma will have the tumor near the center of the vision. And when we have to treat a melanoma in the very center, sometimes central vision can be lost or be significantly reduced. And although the central vision may be impaired due to the location of the melanoma, visual improvement may continue in the retina periphery. So the side view, which we don't give as much credit that I think it deserves, but your side vision helps you very much to get around, to notice that there's something coming off to the side, to help you with driving. And if we can improve a person's peripheral vision, even though the center has been affected, that is very helpful when a person uses both eyes together. It improves your overall field of vision. So it's very important not just to be fixated on the macula, which is your central vision, but your peripheral vision is very important for a person's visual experience. As I said, it's important to do what we can to maintain peripheral vision. So what do we do after the tumor's been treated and surgery has been completed and the plaque has been removed? Usually by 1 month after the treatment, we can see some signs when we examine the eye that the tumor itself has started to respond to the radiation. And usually what we notice first is that the color of the tumor starts to turn a little more yellow and fibrotic. And that's the tumor that's becoming now a scar in the eye. At 3 months after surgery, that's usually long enough to repeat some of the tests that were done at the initial visit. And that can sort of give us information, and it's helpful because it can show that some of the features of tumor activity have now gone away. And certainly we do look at the size of the tumor afterwards. And I know that everybody likes to see that the melanoma has shrunk, or it's less than it was before. In people who have very small melanomas, to start with, we don't see as much shrinkage right away. Sometimes it can take 6 months to a year before we actually can measure a slight decrease. In a person with a larger tumor, we tend to see shrinkage happening a lot sooner. So that's something to keep in mind. It's not a bad thing if we don't see shrinkage at your visit. The only thing that concerns myself is that if we see growth. If we don't see anything growing and we see things about the same or shrinking very slowly, that is a successful treatment. And certainly we continue these detailed ocular exams every 6 months after the tumor's been treated. And some of the things that we look for, not only do we confirm that the tumor has responded, we're looking for the side effects of radiation. Because if we can find things as they're happening, we may be able to intervene sooner than waiting for the vision to be significantly impaired. probably more importantly, is it's very important to look at the other eye, because most of the time, an eye that has been treated with the melanoma is going to be a person's weaker eye. We have to be sure that we're not missing anything going on in the better fellow eye. So what other symptoms might people experience? So these are things that I've sort of noticed over time, and I think it's important to talk about them because sometimes when they occur, people can be very concerned and worried. One of the things that can happen to some people is that people experience extreme fatigue for maybe 1 or 2 months. It doesn't happen right away, but it happens maybe about a month later, that people feel really tired after the surgery, and there seems to be no apparent reason. Why this happens, we don't know. I don't have a good explanation, but what I do know is that it goes away. And I always tell people that this is normal, and maybe it's a reaction of the dying tumor or some inflammatory response, but it goes away, and it's important to just sort of push through it because it will end. Another thing that happens, in about 1 to 2 years after treatment, some people may notice a recurrence of flickering or light flashes that remind them of the symptoms that first brought their melanoma to attention. And why this happens, we usually see this symptom when we see some shrinkage of the tumor. And it is most likely related to inflammation associated with dying tumor, that the tumor keeps shriveling. And so it's setting off little signals in the retina that give people flickering. It is not a sign of the tumor coming back. And I think this is what worries people who start to get this when everything has been going well. They're worried that perhaps that cancer is become reactivated or returning. And whenever this happens, we do recommend that we look and confirm, but I have not seen the situation in a person whose tumor has come back. And this is just more inflammation, more dying tumor. Other things that people may experience: droopiness of the upper eyelid. Oftentimes, within the first couple of months after the surgery, a person's eyelid on the eye that was treated may be a little bit lower and may not open as wide. But this almost always gets better by doing nothing. Just watch it and it will improve. But there are some people for whom this droopiness will continue, and if it's still a little droopy or asymmetric by 6 months, eyelid surgery can be done to make the eyelids symmetric between the eyes again. Double vision. This is something that is fairly normal in the first couple of months, but it almost always improves without having to do anything else. But if a person whose straight ahead vision remains double by 3 or 4 months, we will often have them see an eye muscle specialist for evaluation. It may be that that person may need one of their eye muscles just tucked a little bit so that they can maintain single vision when they look straight ahead. Some people continue to get irritation of the eye after the surgery, and sort of this red irritated eye. We do see this, and this is usually caused by dryness due to healing of the surface tissues from the surgery itself. We recommend using plenty of artificial tears. These are the moisture lubricating drops to keep the tear film present so that the eye is comfortable. There are other sorts of treatments that can help for dry eye, and we would be happy to recommend them. And I often tell people that this gets better with time. It's usually, the tissues are most irregular close to the time of surgery. As time goes by, the surface of the eye actually continues to smooth out so that these symptoms become less. So to summarize, we've reviewed some basic things about ocular melanoma. I've shared with you the surgery using brachytherapy and surgery where we use vitrectomy in instances. I've talked a bit about getting through the plaque week, the removal in the office, and a little bit about visual recovery in the short term. And I thank you very much for being here at this webinar. And I understand that we have some questions, and I'd be happy to address these. So some of these questions, let me just repeat. Let me start with this one. Can cancer of the eye be cured completely? And I think that this addresses two things. So let me talk first about the eye. We are very good at killing the melanoma in the eye. It's, different centers may do different things or have a different experience, but it is unusual if we cannot successfully destroy the melanoma in the eye. So can the eye be cured of cancer completely? Yes. However, we can't talk about the eye without talking about how this cancer affects the whole body. And even though the melanoma may be dead in the eye, we still recommend that people be monitored systemically. So that means seeing an oncologist who can do screening examinations to make sure that this cancer is not coming back elsewhere in the body. We know that doing screening examinations is important because it allows us to find, if the cancer ever were to spread, we can find it as early as possible. And if the cancer spreads elsewhere, if it's picked up early, there are many more options for people than if we don't do the regular screening by an oncologist. Here's a question. Does using an old prescription affect eyesight or health? So this sounds like a very general question. So an old prescription, so I understand this is probably a pair of glasses or contact lens prescription that is out of date and a person is wearing this. You may not see as well if you're not corrected to what the optimal correction might be, but there's actually no physical harm to the eye if you wear a glasses prescription that's out of date or may not be your own. Okay, here's a question. I have lost flexibility in the eye, presbyopia. Presbyopia is when you lose the ability to accommodate. And accommodating is the ability to focus up to something very close because the muscles around the iris and the ciliary body are very strong. And unfortunately, as time goes by, we lose the strength of those muscles. It says, this person has to use different pairs of glasses as they age. Any best solution? Well, even though this doesn't have anything to do with melanoma, it does have to do with finding the right vision for your abilities and tasks to be able to do the things that you like. And there's at least half a dozen different solutions for types of glasses for reading, whether it be contact lenses or having glasses for single vision or glasses that you can wear that cover all of your visual needs. And there are even surgical solutions. So what I would do is you need to speak with your eye care provider and be very clear about how you like to use your vision and what your specific needs are, what is the most important thing you like to do, and you will likely find a good solution. Well, thank you very much for your attention and time.